awareness about colorectal cancer and screening. Special thanks to speaker speaker Dr. Simi Joseph, who said yes to our call in spite of a busy schedule. Thank you so much, Dr. Joseph. Here about Dr. Joseph, she is a gastroenterology advanced practice provider at Lakeshore Gastroenterology and the manager of Ambulatory Surgery Center, Endoscopy Services at Northwestern Medicine. In addition, she is an adjunct faculty at Benedictine University and an international faculty at Mahe University, India. Dr. Joseph completed a BSN from Mahe University, India, MSN from North Park University, DNP from Loyola University, and is currently pursuing a PhD from Northern Illinois University. Furthermore, she is a research scholar who's completed the clinical research postgraduate program at Harvard Medical School, Boston. She continues to serve as a peer reviewer for Gastroenterology Nursing Journal and has co-authored Gastroenterology Nursing, a core curriculum, 6th edition. She has significantly contributed to the growth of advanced practice providers through sustained contributions of advocacy, mentorship, research, and leadership over 14 years of her APN career. She is an active member of national and state organizations such as the Society of Gastroenterology Nurses and Associates, Gastroenterology and Hepatology Advanced Practice Providers, and the American Association of Nurse Practitioners. In addition, she is a great contributor to Indian nurses by serving on the boards of the Indian Nurses Association of Illinois and the National Association of Indian Nurses of North America. She has been the Education Chair, APRN Chair, Research and Grant Committee Co-Chair, Executive Vice President of INAI, and now the APRN Chair of NINA. Dr. Joseph has received many accolades for her contributions to APRN practice, including the National Award for Excellence in Clinical Practice from AANP and America's Top NP Award from POCN in 2022. Thank you for joining us today, Dr. Joseph, and over to you, Dr. Joseph.
Thank you so much, Pramila, and also the New Jersey NINA chapter for inviting me for this, important topic, I would say. And we've been talking about this particular topic for some time now. The more and more awareness is more and more good to prevent spread the awareness of colon cancer screening. And I see a lot of men, on the call. So that's a good thing, So men, they are the hardest people to push for the colonoscopy screening. So we, as many nurses, every household in the U.S. have nurses in the but their husbands do not go for their colonoscopies because they don't believe in these kind of screening protocols, or how much ever we explain, it's very hard for them to understand. So here we go. I'm going to share my screen and I will explain as much as I can, and also in simple term. And so many healthcare providers are on the call, so they might feel like this is pretty simple, but I just wanted to make sure we are capturing the wide audience. All right. You're seeing my screen, Pramila?
Yes,
we can see it.
Okay, good. All right, so let's talk about colon cancer screening and why we wanted to screen for life. As any type of screening procedures, colon cancer is also a part of the screening protocol in all over the world. So let's dive more into the basics of your anatomy, and then we'll move to I'm sorry. Maybe we can mute whoever is talking. Is that okay? Okay. So this is a picture, as you can see, it's your internal anatomy of your large intestine. And in the middle, you will see the small intestine. And then on top of it, that's your stomach is located. So colon is the largest portion of the square shaped picture that you are seeing is the colon. It's a long muscular tube, which is almost 5 feet long. And it also considered as colorectum because colon is separate than rectum. Rectum is the last part of your colon. So we consider as a colon cancer as well as rectal cancer separate because it's anatomy wise, it's called as separate. And colon is the large intestine and small bowel is your small intestine. Rectum is the passageway that connects the colon to the anus where you empty out your stool. So in your anatomy, I wanted to say this because sometimes, doctors talk about after your colonoscopy, they'll say right colon versus left colon. You have a polyp on your right side of the colon and we removed it, so those kind of conversations, sometimes people don't understand. So that's why this anatomy will help. If you see that in the picture, it's called the cecum. Cecum means that's the portion that is starting off the colon, which connects with your small intestine. So, and then from the cecum, it goes into the ascending colon, it goes upwards, and then it makes a turn to around your liver area. It's called transverse colon. And then it comes down into your descending colon. And then it's your S-shaped, or there's a kink there, or it's the stool have to make a turn. That's called sigmoid colon. And then leading towards your rectum where your stool comes out. So your anatomy sometimes may not be straight like this. Colonoscopy in some patients or some people may be very difficult when your colon anatomically is twisted, or maybe it's in a different shape, or it's kinked somewhere. So that's a couple of reasons like people have colonoscopies not successful. But most of the time, when you're going through a colonoscopy, the expert gastroenterologist is able to go through your rectum all the way from the bottom and go through your left side of the colon first, then go into the middle, and then you check the right side of the colon up to the cecum. Cecum is very important because there's a lot of cancers are hiding in that area, which is called the cecum. It's a pocket shaped. Basically, according to the national standards, the doctors are supposed to spend certain minutes in the cecal area so that they visualize everything properly to make sure there's nothing there, no cancer signs there, before they come out of a patient. So that is standard.
For a view. And
any questions?
Yeah, a lot of traveling.
All right. So let's move on to the basic thing about colon cancer. Is what we need to understand is what is polyp, right? Polyp is a non-cancerous growth. So if you have a polyp, it's not cancer, not always cancer. So the polyps are non-cancerous growth that develops from your muscular layer of the colon or in the rectal area. Polyps are very commonly seen, so don't be worried if your colonoscopy shows there's one polyp or two polyps. That's very common after the age of 40 years, even in younger age, in 30s and 35, we see colon polyps. And those polyps, at least 10% of the polyps are most of the time progressing into invasive cancer, but rest of them are very benign and they had to be removed. That's the reason for our colon cancer screening. And typically the polyp growth, we consider as it takes a small polyp takes 10 years at least to grow into a cancer stage. That is one of the reason we consider a screening colonoscopy as a 10-year follow-up. And if you don't have a polyp, that's what I'm talking about. So that's why every 10 years you need to go through a colonoscopy. That is the underlying reason is the growth of the polyp. So if you have a small polyp, we don't consider that as a fast growing polyp and getting into a cancer stage within an year, unless you have some other risk factors. So that is the basic understanding of a polyp. And you see these pictures. These are different types of polyps in your colon. The first one is very small polyp. You see only one in the colon. The second one, you see many in the colon. So all of those polyps will be coming out during a colonoscopy. And the third one, you see one polyp, which is kind of a mushroom looking. So usually they completely remove it. They have technologies to cut it out and send it for testing. The last type of polyp that you see is a bigger polyp. But the technology has been so advanced in gastroenterology, so we are able to completely take out these kind of polyps during the colonoscopy procedure. The patients currently do not have to go through a surgical procedure or cut out the colon or any type of advanced, cut open invasive surgeries can be avoided. When you do a colonoscopy, everything should be able to taken care unless it is, it has already turned into cancer. So the colon polyp, there's two different types of polyps that we consider pathologically, how to distinguish benign versus abnormal, or maybe this type of polyp has a little bit of changes you will see in the future. So you have to be worried about, you have to completely remove it. So polyps are classified as adenoma polyps and also serrated polyps that you see on the top. The adenomas are basically, it's a cancer, precancerous we call it as. You will not say a cancer term when doctor's talking to you. They'll say you have adenoma polyps, so you're supposed to follow up within 3 years. Or if you have so many adenoma polyps, you cannot wait for 5 years or 10 years because you need to have your colonoscopy within certain number of years because these adenomas can come back. Not necessarily the same polyp, because the same polyp will be removed during your colonoscopy. So the adenoma polyps, if you have an adenoma polyp, your risk for developing these type of adenoma polyps in a couple of years or 2 or 3 years or even 5 years. So the doctors will tell you, you have these kind of polyps, so your repeat colonoscopy will be in 5 years or 3 years. Serrated polyps, they are saw-toothed appearance in the microscope. That's what it's called, the serrated polyps. And they are kind of little dangerous type of polyps, we say. So the 3 types listed at the bottom: serrated adenoma, hyperplastic polyp, and sessile serrated polyps. So the pathology will tell the doctor that what kind of polyp it is when they remove it and send it out for testing. The sessile serrated polyp, as you can see, the blue color you see is not the colon, but what a GI doctors do is they inject some certain type of dye so that they can see the color or how wide is the polyp in a colon. Because if you see the left picture, it's very hard to see that type of polyp. You can easily miss it. So nowadays, artificial intelligence is being integrated into colonoscopy. Not on the colonoscope. This basically AI technology is in the monitor. So if even if the doctors miss a polyp, the AI technology will light up that area and tell the doctor that look at here. This is suspicious of polyp. So it's been very advanced in gastroenterology. So AI is coming more and more for physicians to completely determine if this is a polyp or not, or they should not miss anything. So the colonoscopy is 100% successful for removing any type of cancerous lesions. In the past, I have seen personally many colon polyps are missed by the doctors because these polyps sometimes covered by poop, or if you're not clean enough, then it's hard to see these kind of flat type of polyps. So that's one of the reason the doctors mainly miss, polyps or cancers. So, a couple of important things that we have to make sure is the preparation of the colonoscopy. That's why very important. You should not have any stool or anything in the colon for that doctors can see these kind of polyps and remove it. So colorectal cancer. So a little bit about cancer and its stages of the colon cancer. So personally, I know some of the some of the Malayalis or Indians had colon cancer in the US, and they had to go through surgery, they had to go through chemo, radiation. So I've personally known some, I've talked to them because some of them, they ask me questions because, many people know me in a gastroenterology field. So they send their reports and ask about, the right advices just to make sure this is something that they have to worry about it or not. So it's more seen in men, I have to say that, in US, in Indians. So cancer, this is basically the polyp that we talked about. It's actually growing, the cells grow out of control. And this abnormal growth, which is called as polyps, form into, colon cancer in the colon or in the rectum. And over time is the culprit here. As you wait and you don't check out if any symptoms you have, then this grows into cancer stage. So for another example, if you wanted to say about stages of colorectal cancer, these are the types of polyps that you see in the colon, and the stages of colorectal cancer is, basically you can see in the picture. The first picture, the stage 0 in situ, that's basically a polyp, is a small growth you can see in the colon. And that cancer is just in the polyp. It's not even spread anywhere in the colon wall or anything. So you are saved when this stage 1 or stage 0 type of cancer is removed. Stage 2 is basically local. The local is, it is basically invaded into the wall of the colon or in the rectum. It can be removed, and most of the time that area need to be surgically taken care for stage 2. That's for the safety of not to have reoccurrence of the cancer. So people have to go through surgical procedure for stage 2 colon cancer, but not necessarily chemo or radiation, because that's completely taken care through surgery. And they may need a repeat colonoscopy every year. They have certain protocol to follow in order to check out their colon is okay. There's no recurrence or coming back of colon cancer. And stage 2 and 3, we also call as a regional spread of the cancer. That means the cancer is spread to the nearby tissues and the nearby lymph nodes. Lymph nodes are basically, if your cancer is spread to lymph node, it can spread to any part of your body easily. So when you have these kind of flat, big polyp, if your pathology says cancer or early changes of cancer, you go through a lot of testing to find out what type of staging criteria are there. So what stage is your cancer? Sometimes your colon has to be removed to understand what stage is your cancer. So they will have the cancer removed first, and then advise you have to go through chemotherapy to make sure there's no other if the lymph nodes spread, especially your chemotherapy has to go through your body certain cycles to make sure this cancer is completely killed. The stage 4 is the distant metastasis. That's basically your cancer is spread to other parts of the body. Most of the time, liver and the lung is the common areas where colon cancer is spread. So if you have that kind of obstructing lesion, that means the colon is completely blocked. You may require surgery because that's the only way that you can function. Otherwise, you'll be miserable. Even though you got to go through that surgery, you will still have to go through chemo. And if it is in the rectum, so that different type of treatment too. So stage 4 is hard. If you're reaching stage 4, that is hard to treat. So it's like an end stage colon cancer, I would say. So colon cancer treatment, I basically talked about it. So I just wanted to stress again, in situ or stage 0 of the colon cancer can be completely removed by colonoscopy procedure. And we use this certain type of technologies to remove the polyp completely and send it out. If it's a local spread, the surgery is required to take out that colon portion of the colon and send out for testing. And if things are okay, that's all you need. Regional spread, you need chemotherapy, and distant metastasis needs sometimes surgery, chemo, all kinds of supportive measures the doctors will recommend in order for you to have a survival for another 3 years or 5 years. Rectal cancer, it is also in a high incidence and prevalence is seen in the rectal area. Rectal area is very hard to treat surgically. It's because, as you can imagine, it's right in that opening of your rectum sometimes, or it's towards very close to the rectum. If you cannot remove your rectum completely, it's very hard, right? So when you think about it. So surgery is sometimes is needed to remove the lesions in a different way, not like cutting the entire part out. They have to remove the lesion. They have to do the chemotherapy. And most of the patients with the rectal cancers have to get the local radiation therapy in that area to shrink the tumor first before even they go through any type of surgical procedure. And sometimes these rectal cancers are miserable for patients because it will bleed, it will block, and you won't be able to go to the bathroom. In that case, certain cases when you're going through this treatment, some patients get colostomy. Colostomy is it's a bag that people wear, right, for the poop to come out in your abdominal area or the lower part of your, abdominal area. Sometimes it can be a short term until you go through this treatment, until the surgery is completed, then it can be put back in some cases. So those are the cancer treatment scenarios that you commonly encounter for rectal cancers. So what are the symptoms of cancer? It's basically, if I talk about these symptoms, it's not always cancer, but at least these are the warning signs of something is going on in your colon. You need to have a colonoscopy or check with your gastroenterologist. Someone I know recently went through chemotherapy. He had constipation for some time, and constipation, we don't worry about it. Sometimes we drink a lot of water or eat some more fiber in your diet, then you feel like it's normal. But, sometimes you have to think about other symptoms too. When you're having your change in your bowel habits, all of a sudden you cannot go to the bathroom. How much ever you sit in the toilet, it doesn't come out. You feel like it's blocking feeling, or it is hard to push to come out. And you're eating okay, you're drinking water enough. Why is it happening? And are you losing weight? And are you seeing some blood in your stool? Blood can be bright red blood, or it can be sometimes darker black color blood too. The bleeding reasons or bleeding signs, I can say, when I showed you the anatomy. So when anything coming out of your rectal area, like blood wise, or even the left side of the colon, you will see bright red blood. But if anything is bleeding on your right side of the colon, it takes some time for your blood to come out of your poop, right? So usually, you don't poop every single minute, right? So your stool takes time to travel through your colon to come out. So when your stool is mixed with the blood and bile, that's how it turns into black color. So if you see black color, that is also a concern that there is bleeding going on. Poor appetite, and on top of it, when you have these symptoms, check it out and with your doctor and see if you're anemic. Sometimes your anemia is a very common symptom for people to go through colon cancer type of a screening, because why you're anemic, all of a sudden. So that's some of the symptoms and warning symptoms or signs and symptoms that you have to consider. If you haven't done your colonoscopy, this is the time to do a GI workup. When you're anemia or blood in the stool, sometimes the doctors say check the upper, like stomach also getting evaluated, as well as colon also get evaluated. So risk factors for developing polyps or even colon cancer. I put it into left side and right side, can change and cannot change. So that means these behavioral type of risk factors can be changed in your daily life, right? Being overweight, you're not very physically active, you don't do exercise, your diet is high, rich in red meat and processed food, high temperature, cooking. If you remember, in India, we used to fry a lot, right? That frying and cooking meat and everything in high temperature, that is not good to be in the diet. Low levels of vitamin D. smoking, and alcohol use. So these are the dietary habits that are known to cause high risk for colon cancer. And all are in a bad category. We all know these are things that good for you for any type of chronic diseases. So it's similarly, these are the culprits for colon cancer also. Cannot change. That means, your age you cannot control. So that's the reason, when people say, okay, you're 45 or 50, do your part, do your screening, do your mammogram, do your colon cancer, do your, the prostate screening, any type of screening, there is a certain age to do it. So when you cannot change your age, do your, checkups. Then personal history of polyps or colon cancer. That means you have a history of polyps in the past, never forget to follow up with your colonoscopy. And if you had a colon cancer, that is even, you cannot change anything. You're very high risk for recurrence of colon cancer. So make sure you continue with your screening protocol. If it is every year, I know screening protocol for colon cancer is every year for 2-3 years. And then if things are fine, then it is 5 years. Personal history of inflammatory bowel disease. Inflammatory bowel disease are very commonly seen nowadays in Indians. It's called colitis. There is 2 different types of colitis. It's inflammatory, Crohn's disease and ulcerative colitis. Commonly seen in young age, Crohn's disease and ulcerative colitis. Middle age is very commonly seen. So if any of your personally have these kind of conditions, then you are more risk for getting colon cancer. The screening guidelines for people with inflammatory bowel disease is there. So if your GI doctor will recommend you how often you need to go through a colonoscopy. Even if you don't have symptoms, you have to go through your colonoscopy. Then family history of colon cancer, and also adenoma polyps. I remember I talked about adenoma polyps. So if your parents or your siblings tell you that, oh, they had a big polyp, which was precancerous, they had to take it out, or they had to do surgery, even though it's not cancer, but in your family, there is an adenomatous polyp, then that means you are in the category of risk factors to, risk to get colon cancer. Sometimes, in the US, I have seen nobody talks their personal medical history to each other. Even if you're a sibling, they may not tell you. So sometimes patients even say, oh, my sister went through a colon surgery, but she didn't tell me what it is for. She didn't tell me if it's cancer or not. But these are things very important for other family members to know so that they can also do their, screening portion. Having an inherited syndrome, genetic syndromes like Lynch syndrome. Lynch syndrome is something that it's a risk that a person has to get all the different types of cancers, like endometrial, ovarian, small intestine, stomach, bladder, breast. In those kind of genetically changed, whatever the risk for the person, that person is will have risk for different types of cancer. So the colon cancer is included in that. Then the race, I can tell you example is in US, African Americans are high risk to get colon cancer. So even if our guidelines have 50 years of age, you need to get your screening colonoscopy. For a African American, it used to be 45 because they are very high risk to get colon cancer early in their age. So their guidelines were even different from before. Type 2 diabetes. Type 2 diabetes is also known to cause in the studies that high risk for colon cancer. So this is, I wanted to show you, I know this is not easy to understand, but this is a relative risk. Relative risk is comparing the risk of diseases among people with particularly exposed to the risk factors and people who are without exposure. So they are comparing, what are the relative risk for these type of categories, hereditary, modifier factors, and also some of the physical activity and the dietary intake. So they did studies to see if you have, or if someone have these kind of risk factors, how how their relative risk increases in their family to get, increases the risk to get a colon cancer. So if you can see, for a basic example is if your risk is more than 1.0, that means you are very high risk to get colon cancer. So that's why one or more first degree relative, that means your father, mother, or your brother or siblings, anybody had colon cancer, you are 2.2 times risk to get colon cancer. So your risk increased to get a colon cancer. And then first degree relatives diagnosed before the age of 50, it's even very high, 3.6 times your increase to get colon cancer. And 2 or more first degree relatives, you have couple more, runs colon cancer run in your family, that means 4.0. Its risk increases with these kind of, scenarios. So all the way to the bottom, you can see physical activities, 0.7. That means if you are more physically active, daily exercise, you're on top of it, then your risk is very low. And the dairy, people who have consumed dairy products have a lower risk for getting colon cancer. I'm not sure what's the science behind it, but that is from all the studies so far we have done in a patient population who had colon cancer. So you can say that dairy products may be a protective measure for preventing colon cancer. So these are some of the numbers I wanted you to see what is the predicted statistics of 2023 by American Cancer Society. New cases of colon cancer based on the previous years, they are predicting 106,970 cases will be diagnosed in 2023. And 46,050 new cases of rectal cancer will be diagnosed this year. And lifetime risk, it is becoming more and more equal. Men and women are almost equal, the risk to get colon cancer. And death-wise, it's a third leading cause of cancer-related death and second most common cause of death in men and women. That is the reason we are more and more talking about colon cancer screening. And these many deaths are predicted in 2023. And some of the younger age population has seen in the previous data, it's seen like a lot of less than 55-year-old is getting colon cancer. That is the reason, we are changing the guideline to 45. And 12%, that's predicted, individuals younger than age 50 will get colon cancer this year. This is from the United States Cancer Statistics data visualization from CDC, and also there's a surveillance system. It talks about how is the current colon cancer test usage, like colonoscopy or any type of test usage in adults 50 years of older in 2018. According to each state, you can see nobody is more than 75%, so there is a lot of room to improve to get colon cancer screening in every state in the United States. This is something I wanted to show the trends in colon cancer incidence. That means the number of cases that is coming up. It's from the previous data. The first picture shows that in male and female, less than the age of 50, the colon cancer is significantly going up and up and up. It's not reducing. The line is not going, it's not coming down. So as you can see, the different age category where the line is, where we are seeing the, colon cancer at this type of age. I think the screening age is, pretty much after the age of 50, that a lot of patients are getting their colonoscopy. That's why these numbers are coming down. So that's good. We wanted to make sure that is almost, 90% or 100% achieved, right? So the number which is going up is not good in the younger population. So that's why we have to catch the younger generation to get the colon cancer screening. This is the top 10 cancer by rates of new cancer cases. Colon and rectal cancer is the fourth one in 2019. top 10 cancer by all races and ethnicities, male and female. It's still high number in colon and rectal cancers. This is the rate of new cancer by race. It's the whites, blacks, American Indians, and Asians. And I believe we belong to the Asian and Pacific Islander, which is non-Hispanic. That's where we belong to. And the Hispanic. So we are not so bad. We are coming up higher and higher, close to Hispanics. And that is also not good. That's why Indians need to get their colonoscopies like all the other, races and ethnicities. When you think about it, Indians have a lower risk for colon cancer, but it's in India, compared to whoever living in India and compared to who are living in the US, it's very different. It's because of the dietary habits, what we have in the US. That's why our risk has increased to get colon cancer. This is just showing, how is the new cancer by age group, all races and ethnicities, how the numbers are higher as the age grows higher. So I want to show you this 2020 data. This is from Preventive Task Force. In 2021, they changed the recommendation to cut down the age from 50 to 45. This is the reason, more and more people should get colonoscopies, but still it's not achieving. 71.6% only got colonoscopy between the age of 50 and 75. And all the testing they did screen everything, colonoscopy, other stool test, CT colonography, everything they said they calculated, and still it's only 7.6% are getting colon cancer screening. 64 million got screened in 2020. 19.9% adults age 15 to 75 who has never been screened for colon cancer in 2020. 67.7% adults age 50 to 75 who were up to date from the data analyzed from 2012 and also up to 2018. So this is something that, it's an eye opener. It's US system is very good in collecting data, all the statistics, so that they can look at the predictions and they can change their guideline. They can go around and talk about it more and more to give the importance of, screening procedures. And that's where we are, we are screening colonoscopy starting from the age of 45. People with good health and life expectancy is okay. That means they can go through the screening process until the age of 75. So screening is always preventable, right? Preventing cancer. So we remove the precancerous growth, we detect the disease early, and we treat, and we are successful, and our life expectancy will be higher if you detect it early. So that's why, we consider from 45 to 75, you should go through screening protocol. If you're at the age of 45, you had a colonoscopy and there was no polyp, then you go at the age of 55. So it's like 10 years. Then if you're age 55, maybe you had polyp, then your screening may be changed to 5 years. Then next will be at the age of 60. So in your lifetime, you may need to get your colonoscopy maybe 3-4 times or 5 times based on what's the finding. People from 76 through 85, the screening should be based on the overall health and life expectancy, some preference. I had patients who in their 90s, they wanted to get their colonoscopy screening because they had a precancerous polyp, and they keep coming. They keep coming to go through the colonoscopy just to make sure they are okay and they don't have any polyps and remove it. So according to, anesthesia guidelines, if a person is okay to go through sedation type of a procedure, and they can still, the doctors will accommodate their request to continue to screen. But if they have some complications of anesthesia in the past and they are not a good candidate to go through the screening, the physicians will tell you that the risk versus benefit, right? If they're going through this procedure, take this risk, it's not benefiting your life expectancy. So what are the stool tests, screening tests available? There's stool-based test and visual exam. So visual exam, we talked about this colonoscopy, and the CT colonoscopy is called as virtual colonoscopy. That is done in a person if a colonoscopy is not successful, but there is a suspicion that this person may have a colon cancer. Then the doctor will send you for a CT scan. So CT scan, you basically go through all the preparation of colonoscopy, but it's a CT imaging type of a technology to look at the colon to see if they can see any polyp where you failed the colonoscopy. Flexible sigmoidoscopy, it is a smaller portion of the colon, the left side of the colon only we will check during flexible sigmoidoscopy. That used to be a routine guideline from the age of 45 to get a flexible sigmoidoscopy to check it every 3 years or 5 years. But no doctors are considering that as a screening anymore, because when you can go through a colonoscopy pretty easily, why to go through all the other testing. Then the stool-based testing, we can talk about that. I know I touched colonoscopy, CT colonography, and flexible sigmoidoscopy. So the test time interval for colonoscopy, if there is no polyp, it's 10 years. For CT colonography, if you cannot go through a colonoscopy, that's the time somebody will be sent for a CT scan. That is also every 5 years. Flexible sigmoidoscopy every 5 years. But the first recommendation is colonoscopy. The fecal test, the stool test, you probably have heard it, and maybe you want to do it because it's very easy to do it, right? It's a stool test. You poop it and it's in a card, you test it out. And one of the other tests, the newer test is sending it out to a bigger company to check for your DNA. So the FIT test is performance at the office level. When you go to the doctor's office, sometimes they do it, both the stool test. It's very easy to collect, but it requires multiple samples to say that you do have some bleeding going on, or you do have, it is not accurate to test for cancer. It can only tell you maybe there is some blood in the stool that also can be missed. Okay. Cologuard is the newer test for the past maybe 5 years, I would say. That is used nowadays for somebody who's really having a hard time going through colonoscopy, and your stool can be tested for DNA to see you have high-risk polyps or even cancer. But that will not tell you have completely cancer. There's many false positive results have come in, and people are getting nervous and they run for colonoscopy when the test becomes positive, thinking they have cancer. So it's all of those tests. For a general practitioner standpoint, they can easily do it. They can make patients happy. But as a gastroenterologist standpoint, we do not recommend these as first line, recommendation for screening. So timely colonoscopy is very important. If you have a strong family history, you have to do your screening. If you have a personal history of colon cancer or polyp, personal history of Crohn's disease, of ulcerative colitis, or somebody in your family with colorectal cancer, and also somebody who had a radiation treatment for something else for your abdomen or pelvis area, you are also at risk for getting cancer in your colon. So you have to test it out. I'm going to touch base with the most popular thing that you may have the question about. It's called bowel prep, right? Everybody hates this. The actual colonoscopy part, everybody loves it because you are just sleeping for the procedure for 15 to 20 minutes. When you come out of the procedure, you feel very well, slept and comfortable. But bowel prep is the one nobody likes it. That's the main reason people do not like colonoscopy. So what are the types of bowel prep we have in our US, basically? So polymer-based formulas, it's called PEG-based formulas. It's a very commonly prescribed. It's a 4-liter formula. So that's the reason everybody's like, oh my God, I have to drink that big gallon, right? It's very hard to chug down because the taste is not so great. But polymer-based laxatives are, which is very easy to handle. It's very easy to purge or very easy to poop out. That's what I would say. Hyperosmotic effect, that means it draws in all the water into your bowel, and it helps to make a softer stool and increase your bowel activity and make you poop very faster. Okay, these are the names of the bowel prep available in the market: Go Lightly, Colite, New Lightly, Trilite, Miralax, Half Lightly, Gavilite, Movie Prep. So what are the pros and cons of PEG-based bowel prep? It is a very good prep. It is very gentle to the colon, a safer option for people who have a very fluid imbalance, and safe for people who have kidney disease, liver disease, and heart disease. So that's the main reason we doctors are writing PEG-based formulas. I know it is hard to drink. It's 4 liters. It's large volume. That's all the cons, and the taste is very difficult. And some people have a hard time completing the prep. And they have to go through another type of additional laxative in order to complete the prep. So that is the difficult part about the PEG-based formula. Now, another formula is saline-based formula. So saline-based laxative has a lot of sodium phosphate in it, okay? That is the primary osmotic agent that helps the person to poop. So these formulas are different than PEG. It has come in different lower volumes, so people like it. Many salt contained electrolytes. That's what you usually have in all these formulas. There's tablets available. I would not go with the tablet option because I know that is easy, but sometimes it's not effective to completely clean your colon. The solutions are much better to have a good laxative effect and clean out your colon the best. The soup prep is a very commonly used prep, and I had my colonoscopy at the age of 45, and I used the soup prep, and it's very easy to drink. It's not like a 4-gallon. You see that small 2 bottles there, and you also have to have followed with the water, certain amount of water. So all the instructions will be there. So the currently available saline-based formulas are Clenpic, soup prep, Prepopic, Visicol is the tablet, and then the Osmo prep. The lowest volume is the Prepopic available in the market. So what are the pros? It's easy to swallow, easy to finish it. So it's a better compliance from the patient side. It's very successful colonoscopies for those who are going through these type of formulas. But the contraindications for certain patients because of the risk, they can get a lot of electrolyte imbalance. You got to be very safe to use in older patients who have kidney disease, liver disease, those kind of things. So the doctors usually look at, what is the best option for a patient. So some questions, okay? What is the best colonoscopy prep for me? Really, there is no right answer. So some patients have difficulty going through colonoscopy preparation. So if the doctors know, when they talk it out, they choose the right formula for you. And also the risk factors considering all the pre-existing conditions. What is the easiest prep to take for colonoscopy? I would say there is no easy way to do a colonoscopy prep. You just have to do it. Are you concerned about swallowing a lot of gallon of water? Some people really have a hard time swallowing water because they vomit out, right? So they have to mix it up. Some doctors use a couple of different types of formulas for a better taste and make sure that can be, easily taken. And as I was telling you, the soup prep or the low volume preps are good options for someone who's really worried about the large volume they can complete the prep or not. Insurance coverage wise, it's very different because the PEG is easily covered by all the insurances, but not the other one. So you may have out-of-pocket pay for a sodium phosphate solution. I paid $75 for my soup prep solution. So it's one of the examples. So your copay can be different. What is the easiest colonoscopy prep to tolerate? As I was telling you, different agents are there. The doctors are pretty smart about combining some of the laxatives if they know that this person is not going to complete it. And if somebody's having some nausea problem or vomiting, they will get additional medications like metoclopramide, Zofran, Simethicone, gas medication. So these are the things that additionally people get for taking care of their prep rot, okay? But you talk to your doctor and say that I may have these kind of symptoms. I don't know whether I can take it. So they can prescribe you these kind of medications to get through that, preparation portion. And some people have tried lemon and ginger to get rid of the bad taste in the prep, and that works too. Is there any risk of complications from certain type of bowel prep formulas? So always, consider the advices of the doctor. Don't fight with the gastroenterologist saying that, oh, the other person in my family got a tablet. The other person got Miralax. Why can't I get it? So your physician knows, your risk factors, your medical condition, what is the right thing to do for you, and maybe the personal experience of the physician. Like, the Suprep may be the best option to clean out completely so that they won't miss any polyp. That's the important part about colonoscopy. How many hours before colonoscopy do you start your prep? So that's a very common question we get. So you will be on a clear liquid diet on a previous day. And then usually you start your preparation on the previous evening. Commonly given 2 doses of prep. One you take on the previous evening, and the second dose you take in the morning. So you probably have to get up like 3 o'clock or 4 o'clock in the morning, based on the scheduled time of your colonoscopy. So they will lay it out for you, what time you have to get up in the morning and finish it up. So the preparation has to be completed within an hour. It's not like you can take it forever to drink it. So you finish it within an hour, you'll be hitting the bathroom within 30 minutes. You clear everything, maybe for an hour, then you may go back to bed, So that's the usual experiences. So it's not like you are going to be ever in the bathroom. Some people feel like, oh, I'm going to be, I cannot get away from the washroom. That's not true. So this is an example. A PEG-based formula may take 1 to 3 hours to completely empty. The saline formula may take 3 to 6 hours to get started. Sometimes people have a bad constipation, so they may have like trouble starting the bowel function, right? So I've seen like people prescribing enemas. So they take the enema so that the preparation can be very effective and, start the cleaning process faster. So there are different things you can do in order to make a bowel prep 100% successful. Will you be up in the night? No, you won't be up in the all night. You will be going to the bathroom the 1 to 1.5 hour. Then you will feel like everything is emptied. Then you can go back to bed. Will I be pooping before my colonoscopy? Like some people have a fear, like, okay, is this pooping issue is going to be continued until I get to my colonoscopy? So you may go to the washroom at home, then you come for your colonoscopy. You can still use the washroom before they start you in the preparation. But even if there is a liquid stool in your colon, there is technologies through colonoscopy, we clear it. We have suctions and things that we do during the colonoscopy. Unless there's a huge stool or a lot of liquid, the doctor may say it's a failed colonoscopy. You need to do your preparation another time and do another colonoscopy. So we don't want that to happen because nobody wants to go through this, bowel preparation again. So do your best at the first time. And a little bit of liquid, it's not a problem. They can suction it out during the procedure. You should call your doctor if you forget to stop eating. That means you did not do a clear liquid diet on the previous day. That may affect your prep. Or you came down with some illness, you need to reschedule, and your preparation is not going well, and you may having some severe reaction to the prep, like abdominal pain, vomiting consistently. You cannot stop, you cannot drink it. Those are the times that you have to call your doctor to reschedule the, colonoscopy. I wanted to show you this procedure really quick because it's very important for people who haven't seen.
What happens during and after a colonoscopy? A colonoscopy is a medical procedure that lets your doctor look inside your colon and rectum for problems such as ulcers, inflammation, bleeding, polyps, and tumors. A colonoscope is the tool used to perform a colonoscopy. It is a thin, flexible tube with a light and video camera on the end. It is inserted through the anus into the rectum and is carefully guided up through the colon, all the way to the cecum. The colonoscope can usually be used to enter the very end of the small bowel, known as the terminal ileum. The front tip of the colonoscope contains a video camera, which sends real-time images to a computer screen so that your doctor can examine the colon. The front tip also has a light, a channel for water irrigation, a channel for air and water, as well as an instrument channel. The irrigation channel is used to flush water or air into the colon, to remove debris or stool, and see more clearly what the inside of the colon looks like, and to check for polyps. Special tools such as tiny forceps or wired loops or snares can be passed through the colonoscope to remove polyps and take samples, called biopsy, of suspicious tissue in order to look for signs of cancer. A colonoscopy usually takes 30 to 60 minutes and is performed in a hospital or clinic by a trained doctor, known as a gastroenterologist. You will be offered a sedative to help you relax during your colonoscopy, and you will be placed on your side for the procedure. Your doctor will carefully insert the colonoscope into your rectum and advance it to the end of your colon, to your cecum. The colonoscope bends, so your doctor can move it around the curves of your colon. Your doctor might gently press on your abdomen during the procedure, or ask you to change positions occasionally to help move the scope through the colon. During the entire procedure, a magnified high-definition video from the colonoscope plays on a monitor in real time, so your doctor can thoroughly examine the lining of your colon. Video may be recorded, and photos are taken as well. A small amount of air may be blown into your colon to help expand the passageway so that your doctor can see better. This can make you feel pressure or mild cramping, but can be eased by taking slow, deep breaths. The colonoscope is then slowly pulled out while your doctor carefully examines the inside of your bowel. If your doctor finds polyps or suspicious areas during the colonoscopy, the polyps will be removed and small tissue samples will be taken to be checked for signs of cancer. Polyps are usually not cancerous, but they can change into cancer, and that is why they need to be removed. Polyps are removed with biopsy tools or wire loops that get passed through the scope into the colon. The most common removal technique is called snare polypectomy, where the polyp is surrounded by a wire loop, and then an electric current in the wire burns off the polyp. The polyp is then pulled through the instrument channel and collected for biopsy. Other methods are available depending on the size and shape of the polyp. Polyps contain no nerves, so you won't feel pain during their removal. After your colonoscopy, you will be taken to rest in a recovery room until the effects of your sedation wear off. You may feel some gas or cramping, but this will quickly pass. Because of the sedation used during the procedure, you will need a family member or a close friend to drive you home. You should take the rest of the day off and not make any major plans for 24 hours. Before you go home, your doctor will share the results of the colonoscopy with you. If a biopsy was sent to the lab, it may take a few days or longer to receive the results. Depending on the number and size of polyps found, as well as how clean your colon looks, based on the quality of your bowel prep cleanout, your doctor will recommend when your next colonoscopy should be done. Your doctor will also provide instructions on the follow-up care required at home and how to recognize complications in case they occur. Colonoscopy is generally a safe procedure and complications are rare. If a polyp was removed or a biopsy was performed during your colonoscopy, there is a very small risk that you may have small amounts of blood in your stool for a few days afterwards. However, if you experience severe abdominal pain, fever, dizziness, or continued heavy bleeding from your anus, call your doctor right away. You should always discuss any questions or concerns you have about your colonoscopy procedure, results, and post-procedure with your doctor. Your doctor is there to help you through the process and answer any questions you may have.
All right, so that's the entire thing that we talked about earlier, the anatomy and how it is done, the prep. I think that colonoscopy and animated video was very informational, I hope. So that's basically a colonoscopy procedure is all about. And they talked about complications. It's a very rare. Usually the doctors warn the patients if you see a major bleeding, it's probably because of a bigger polyp they removed. And also they will consider if you're on blood thinners or something, they will change the timing of your blood thinner. They'll tell you to stop taking it for a few days before the procedure and also not to continue right away. They'll give you guidelines on what are the timing to take those back after a polyp removal. And sometimes we also tell not to take ibuprofen, Advil, those type of medication, because that can increase bleeding. So if you had a biopsy done, removed a polyp, we'll say, not to take that for 24 hours. So these are some of the things we tell. Complications wise, usually major one is the bleeding portion if you had a polyp removal. Otherwise, it's if no findings, you're good for 10 years. I just want to touch base about the insurance coverage. Colorectal cancer screening is no cost for any type of insurance, Medicare, Medicaid, or any private insurances, okay? But if you have a problem, I would say weight loss or bleeding or anemia, sometimes the doctors order a diagnostic colonoscopy. So that might be a different scenario for billing standpoint, or even your copay or deductible. That's most of the patients don't understand. Why am I getting a bill or why I have to pay copay for a colonoscopy? It's a screening procedure, but it's based on diagnostic versus screening. So something I wanted to, explain. The other Medicare coverage, everything else, all the stool tests, all the repeat tests, everything is covered by the insurance. And I hope I touched everything. And this is the time for questions. I know we went over 5 minutes. I'm so sorry. If you know what this is DVD player is, that means you should schedule a colonoscopy. That means you are the age of 45 and above. Thank you so much.
Thank you, Simi. That was very informative. And I have a few questions. Some of the questions were asked before you completed that portion.
Okay.
Let me read that question. The question, is the colonoscopy test painful procedure, or is it under local anesthesia?
Okay, I know I did not go in detail about anesthesia. Anesthesia is two different types. One is, it's not local, first of all. People used to do without sedation. A few years back, I've seen, strong men, they'll say, I don't want sedation, I'll go through the procedure. So it can be done, but it's very painful if you don't get sedation. That means you will have cramping during the procedure, you will feel it, the scope going through, and you don't want to feel that. And you want to be coming out of a safe procedure as possible. You don't want to poke your colon if the instrument is passed through and you're moving around and you're uncomfortable. That affects the performance of the colonoscopy. That is the reason sedation is required. And nowadays, nobody does non-sedated colonoscopies. So two sedations are, one is under the anesthesia type of sedation, which they give propofol. Propofol is the drug, Jackson juice, we call it as. Michael Jackson, died from it, but that scared a lot of patients at that time, but no more. It's a very safe drug and safer for older people too. And that's what the anesthesia doctors use depending on your weight and age. And you come out of the anesthesia right away. Once your procedure is done, you're awake and it's gone out of your system. So that's the beauty of the anesthesia type of support for colonoscopy. The moderate sedation is called twilight sedation. That means you will be aware of what's going on, but you won't have any pain or anything. You probably won't remember anything later on, but during the procedure, you are aware of what's going on, but no pain or discomfort.
I hope it helped. There's one more question. Even this was asked before you covered that portion. Is Cologuard same as a colonoscopy?
So the Cologuard is the stool DNA test. Colonoscopy is the visual test under sedation. Okay, so it's two different types. One is the stool test, one is a visual-based test. Stool test or Cologuard is the kit will be sent to your home, and then you collect your own stool and you send it back to the company. So that is testing for, there is certain type of DNA is tested because your polyp, if you have a growth or cancer, your stool will have this DNA released. Okay, that's what the stool is picking it up to say, oh, you are positive. So that means you have something going on in your colon, not necessarily cancer, maybe a type of polyp that requires removal. That is Cologuard. And colonoscopy is a direct visualization going into your colon, removing it, under sedation.
Thank you, Simi. Third question, next question is there any relation between neurogenic bowel and colorectal cancer and GMO crops?
What is GMO cross?
It
What
says GMO crops, CROPS.
GMO crops. I'm not familiar with that term.
Genetically, I'm sorry, it's
Genetically modified,
Modified.
yeah.
Genetically modified cancers.
no food.
I would
like,
s-
or-
Yeah, I would say usually we consider the risk factors are people who have pelvic type of cancers, like someone who was diagnosed with prostate cancer, they have to go through colonoscopy. Someone who had uterine cancers, ovarian cancers, they all require, colonoscopy as a screening before they do the surgery even. So these type of pelvic type of cancers are risk for colon cancer. And, I mentioned a genetic one disorder is the Lynch syndrome is the one that we consider, different types of cancers in the body, like 2 or 3 cancers you have, then you are at risk for colon cancer too. That's all I have information.
Okay, thank you so much. And next question is there any option if they cannot tolerate too much of PrEP? I know that which you already answered, but this was question just before you covered that portion.
Yeah, the option is some doctors will say, we'll try it and see, if you're not able to completely tolerate it, that means you maybe took only half of the PrEP and the half of the PrEP you were not able to take it, you were vomiting, but they will ask you what's your stool color. If your stool color is brown and things are solid, you can never go through a colonoscopy. There's no way, the doctors can see anything in your colon. So if it's liquid, clear, coming out, you're lucky. Maybe half of the PrEP was good enough. But on the other hand, as an outpatient side, you're limited to do another type of PrEP in the meantime, to do a cleaning. But in the hospital side, we do like some sicker patients unable to take the PrEP, they do the NG tube and give the rest of the PrEP. They can do a couple of enemas to clean up so that they can go through this colonoscopy to check for bleeding. In the hospital side, we do a little bit of tweaking, but outpatient side, if you cannot tolerate, they have to change around a different type of PrEP for you next time. Better taste. The other tips that I always tell patients is put a lot of ice in it and drink it with straw so that you don't have that taste feeling when you drink it from cup, you will feel that bad taste in the mouth, so you won't be able to swallow. I remember when I did it, I did a lot of ice and straw, and I had my sugar next to me. So after I drink, I put sugar in the mouth so that that taste is gone. It was hard. It was very hard to finish the drink, but I'm being honest. But I got to go through it, right? Everybody have to go through it. So you somehow make it.
It's a one-day thing. Thank you so much. Let me read out the next question. Adding thickener to PrEP is effective patient on thickened fluid recommendation. Is it effective for the patient who's on thickened fluid recommendation?
I know thick fluids, if somebody is on thick liquids, right? Like they have swallowing trouble.
Yeah.
I have seen those patients very hard to prep them because you have to thicken that liquid a lot, right? I would say your option is, one best option is you get admitted to the hospital for a prep. We do a lot for patients who are very complicated patients or those who do not have a help at home. They have to go through for some cancer reason or some reason, not for screening. If they don't have any support, your doctor can admit on the previous day to the hospital. They have the privilege like that. They can admit and do a nasogastric type of a prep so that you don't have to swallow. And the nurses can give it and you clean it. The next day after colonoscopy, you can go home. So those things is the most beneficial, I would say, for people who have thickened liquids.
Okay. Thank you. Next question is colonoscopy covered with the HSA? HSA, health savings account.
Yeah. Mm-hmm.
Is it?
Mm-hmm. Yeah.
Okay.
Yes.
Thank you. And next question would be, what could be the reason for lightheadedness and dizziness that continues 2 to 3 days after the procedure?
I would say that might be a side effect from the preparation itself, like you are dehydrated. Some people get a lot of dehydration, and that affects their, after effects after the colonoscopy. I've seen couple of days they are very fatigued and they get dizzy easily. So that hydration takes some time, even if you are getting IV fluid, maybe a liter during the procedure, that's all you're getting, but you probably lost a lot of fluid during your prep. So that your body catching up, it might take a couple of days. That is the common scenario. I can explain why you're having, post-colonoscopy dizziness. Sedation effects wearing off, it can vary from body to body. Some people don't even feel anything after they come out. Some people I've seen, like, discharging is very hard after their colonoscopy because they are very tired and they are dizzy, they can't get up, and we wait and try to push them out of the hospital. Sometimes, go home and rest up. You cannot be in the hospital forever, right? So it depends how you're taking the sedation also.
Okay, thank you so much. And next question would be, what medication should be on hold before colonoscopy?
The major medications are, because you don't know whether you have polyp or not, right? So it's a screening colonoscopy. So when people go into a colonoscopy procedure is done, you're anticipating there might be a polyp removal, there might be biopsies. So any type of anticoagulations, like you're on Plavix, aspirin is not stopped, okay? Aspirin can be continued. That guideline has changed, but all the other anticoagulants and their platelets, like Plavix, Eliquis, those kind of medications, it's all stopped according to the guideline, 3 days or someone are 7 days. Blood pressure medications, you should continue. You should not stop it. Even if on the day of the procedure, you should take your blood pressure medication and come, because that can be difficult during anesthesia. And the other medication change is the diabetes medicine that always have trouble, right? Because you're on liquid diet on the previous day and you don't know how's your sugar. So you are supposed to follow up with your general practitioner to modify your diabetes medicine on the previous day. You may not be taking that much amount of insulin. If you're on an insulin, you should not be taking, because your sugar will go down the next day. So certain type of changes in your insulin should be done through your primary doctor. And if you're on metformin or oral type of medications, I would not take it on the day of the procedure. And also any type of long-acting medications also should be avoided on the previous evening. So that main advices should come from your family doctor about changing around your diabetes medicine.
Thank you so much. That is very informative. One more question. As a GI/NP, do you perform colonoscopy, or do you assist the physician while during the procedure?
NPs were not allowed to do any scopes or anything in Illinois. I know California, I think, they are doing flexible sigmoidoscopy, the lower portion of the colon checking. That is also under training, and a lot of training and certification they have to go through in order to say that they are competent enough to do that. One time I looked into it, that's why I remember. But commonly, nurse practitioners are not allowed to do colonoscopies. It's done by gastroenterologists.
Thank you so much. I think we have covered almost all the questions. If anyone has any question, you can ask Simi directly. There's one more question. Are there any risk factor associated with the colonoscopy procedure?
Only the anesthesia risk is the one we always assess. So they go through pre-anesthesia guideline for any patient who are going through colonoscopy. Most of the time, the doctor's offices will check on certain things. What's your medical conditions to go through a anesthesia type of procedure. So anesthesia guidelines say that you are high risk for moderate sedation. They will consider you as a MAC procedure, monitored anesthesia care type of sedation. So different type of sedation is according to that guideline and according to your pre-existing condition. Other than that, one of the complication is bleeding, right? When you are polyp removal or certain things you do, there's very minimum risk for bleeding. The other one is the perforation of the colon. If the colonoscopy procedure is not done right or not done by a good expert, your colon can be poked, but it's very, very rare nowadays. The one change in the US that has happened is changing the air. We put in the air in the colon to expand the colon so that we can see the colon properly to remove the polyp, right? So nowadays that has changed to CO2. CO2 is better absorbed by the bowels. So CO2 machine is actually connected with the, in endoscopy lab. So you probably haven't heard about it, but the CO2 is something that which prevents from any type of complication. So nowadays there is very easy colonoscopies. You won't get bloated or gas or anything after colonoscopy because there's no air in it. All the CO2 gets absorbed as soon as the colonoscopy is done. You come out good and you can eat good food right after the colonoscopy.
Thank you. Lastly, I must say, you must be exhausted, Simi. You have spoken non-stop for so long. That's from our Namrata Jani.
Thank you. I wasn't sure whether I'll finish within an hour. Sorry, I was going a little fast. But it was a mix of healthcare providers and also I think general public is here. So I wanted to make sure I touch every single thing about colon cancer and, what the importance of colonoscopy and also the procedure. If you haven't seen the procedure, it's good to know how it is done and, anything that you have to worry about. Nowadays, you should not be worried about because technology is good and sedation is good. Complications and everything is thoroughly checked by the doctors. So if your doctor says you're good to go for a colonoscopy, you should go.
I think you covered from A to Z everything. I think you should encourage all of us to go for a colonoscopy.
Yeah, if you haven't gone, that means you have to go.
That's
If
right.
you really want to ask me how it is, you can always reach out to me, but you should not wait for it. One thing you check, as ladies, we all check about your mammogram, pap smear is the same way, you got to check that colonoscopy out.
Thank you so much.
Okay, I think we are done, right?
Please.
Thank you, everyone. Thank you, Dr. Simi, for joining us this Friday evening. And I know preparing all those slides took a lot of time. And though you work in the field, thank you very much. It was very informative. And I want to thank the NINA team. I know our dear Uma is here. And I thought the Deepti was here too. Thank you very much. And I want to thank our AAINJ colleagues who were very helpful in assisting us with this presentation and working behind the scenes. And everyone who came here this evening spent your valuable Friday evening with us. And I hope you all took something home. Go to those colonoscopies ASAP. Thank you once again.
Thank you, everyone. Thank you, Naina, for supporting us, and thank you, the New Jersey chapter, especially Pramila, who reached out to me. I made those slides very fast this week, but if we could have had some time, we would have applied for CEs for nurses, but we can do that next time.
Thank you so much. Thank you for attending, everyone. Have a good night.
Night.
Have a good night.